I'll be talking about obstructive sleep apnea and Down syndrome. We will define first what is obstructive sleep apnea, how to recognize symptoms with obstructive sleep apnea, how to assist patients with obstructive sleep apnea, interrupt the result, and how to manage patients with obstructive sleep apnea. First of all, how common is obstructive sleep apnea? In general population, among normal adults, it's 2 to 4%. What about in children with Down syndrome? It's 30 to 50%, almost half of them. What about an adult with Down syndrome? It's up to 90%. So a very common prevalent disease among Down syndrome. So what's obstructive sleep apnea? So what I'm talking about is, this is someone who's sleeping, open airway, normal breathing. This is someone who has snoring, a partial obstruction of his upper airway, and this is someone who has complete obstruction of the upper airway, and this is what we call apnea. So those who have obstructive sleep apnea, they have recurrent obstruction of the upper airway. Okay. Now, what are the symptoms of obstructive sleep apnea? And I'll present the symptoms in adult and then in pediatrics. Nighttime, patient, most of the time, he's not complaining, but his bed partner is the one who complains. The mother or the partner would say, the patient is snoring. He stops sometimes breathing. He has frequent nocturnal awakening. He wake up, but he does not know why. He turns on the other side, waking up with choking or gasping for air. Sometimes he wake up to go to the washroom. We call it nocturia. Kids, sometimes they wet their bed. They wake up with dry mouth, and they always have reflux at night. During the daytime, adults would have more of, and mainly women would say, we wake up with morning headache, with more of fatigue, and feeling sleepy during the daytime, impaired attention, depression, and during blood work. Sometimes I'll get patients because their blood work showed polycythemia, very high hematocrit, and hypercapnia. Okay, so these are the symptoms of adults. So mainly excessive daytime sleepiness during the daytime. What about kids? So kids, yes, snoring still number one in terms of symptoms, restless sleep, always turning around, and I always hear this from the parents that they're hyper-reflex, their neck, hyper-extending their neck at sleep. They gasp for air, and you see a paradoxical chest-abdomen movement. They're not doing well at school, poor school performance, behavior disruption, failure to thrive, and again, polycythemia and hypercapnia. Now, kids are different than adults. Adults who have sleep apnea, they're sleepy. Kids, have you seen kids at late night when they're sleepy? Their behavior is different than adults. Adults, they want just to sleep. Kids, they start to behave differently. They're hyperactive, attention deficit. And that's what we see with kids with obstructive sleep apnea. They're not the typical adults who would be sleepy. They're more of attention deficit and abnormal behavior just before they sleep. Now, what are the risk factors for obstructive sleep apnea? Number one is obesity. Number two is obesity. Number three is obesity. So the more weight we have, the more fat around our neck, and the more chances that our airway will get narrow and obstruct. Now, in patients with Down syndrome, they have more than obesity. They have the hypothyroidism. We heard that up to 30 to 50% of them have hypothyroidism, which increase the risk of obstructive sleep apnea. They also have the reflux disease, okay, which irritate the upper airway, increase the inflammation. And let's look at their upper airway anatomy. What do they have? The mandibular hypoplasia, the midfacial hypoplasia, the adenoid hypertrophy. We see it in normal kids. Tonsillar hypertrophy, glossotosis, hypotonia, pharyngomalacia with hypotonia, laryngomalacia, subglottic stenosis, tracheal stenosis, and hypothyroidism. They got all the risk factors, more than many things that would increase the chance. That's why we see almost 90% of adults, Down syndrome, they do have obstructive sleep apnea. Okay, you got someone who has all the signs and symptoms of obstructive sleep apnea to your clinic. The mother saying, yes, doctor, he snores, he stopped breathing, he's restless, and he's not doing well at school. Okay, well, before sleep study, we take history and do physical examination. Now, we heard from Dr. Fatima that they have clinical features. Look at the face. This patient had adenoid faces. He's not Down syndrome, by the way. Okay. A clinical feature here where many of you could point many things. High arch palate, large tongue, long uvula, big tonsil. Now, I see normal kids walking around with this big tonsils all the time. Now, before we take it out, we would like to know if it's really need to be taken, and that's why we do sleep study. And what do we call this? Retroganthia, which also known as overbite. Okay, we also look at the anatomy of the airway, and this is the Malambati score used by anesthesia, which basically, this is someone who is unlikely to have sleep apnea, but this is more risk of intubation as well as for sleep apnea. Okay, now the question is, someone who has all the signs and symptoms, clinically, history, and you'd like to do something. Is there a blood work that we could do or something to confirm the diagnosis? Yes, sleep study. Excellent. So we do sleep study. Now, the sleep study, there are different types of sleep studies, especially here in Dubai. You have the home, you have the portable, you have what you need is a full attended polysomnography, full sleep study attended by sleep technologist. Please do not do the home sleep study because the sensitivity is very low, as well as the specificity. And we always lose data at home, and it's not really good for someone who already a risk factor here, someone with Down syndrome, and they need a special care. So what do we do at the sleep lab? We bring the patients, and it's one-to-one, one technician to one patient, and we hook them from head to toe, looking at their EEG, especially the stages of sleep. We go through different stages of sleep, stage 1, 2, 3, which is the deep stages of sleep, and the rapid eye movement, which is the dreaming stage. We look at the EMG, airflow from nose and mouth, snoring channels, oxygen saturation, ECG, chest, abdomen movement, leg movement, video to see any parasomnia, and transcutaneous CO2. So they're hooked up very well, okay? And they like always to take selfie at this stage with all wires. Now we monitor them, and this is what we got. This is a typical recording of sleep study. So someone who's breathing normally, and as of sudden, there's no airflow. So what do we call it? Apnea. Okay? Absence of airflow with chest paradoxical movement. The patient is having obstructive sleep apnea associated with oxygen desaturation and bradycardia. This is a typical evidence of obstructive sleep apnea. Okay, so then we count the numbers of apnea, hypopnea per sleep to bring something, we call it, or calculate something, we call it the apnea hypopnea index, AHI, which is basically just the severity of sleep apnea. AHI of more than 5 is, in adult, is positive. Let me show you. Adult, 5 to 15 is mild, 15 to 30 is moderate, and more than 30 is severe. Kids, 1.5 to 5 is mild, 5 to 15 is moderate, and more than 15 is severe. So this is a typical apnea where you see no airflow with paradoxical chest movement. Okay, another one, this is the hypopnea, which is a reduction of airflow with desaturation. And another one, this is another sleep apnea, where you see a paradoxical chest movement and no airflow. Okay, that's another one. Oxygen desaturation, paradoxical chest movement, and snoring. This is someone who had central sleep apnea with no airflow, no chest, and no abdominal movement. And this is another central sleep apnea. Okay, so where's the problem here? The problem is the patient has stopped breathing, hypoxia, pleural swing pressure, arousal, ventilation, sleep. This is a cycle that happens multiple times at night. What happened with their cardiovascular? There's intrathoracic pressure increase, and with increase in intrathoracic pressure, increasing venous return, leading to increase the preload of the right ventricle, increase the afterload, vasoconstriction because of the hypoxia, and septal shift to the left side, reducing the stroke volume. Now with time, what would happen is remodeling and left heart failure. They're trying to open this airway, upper airway. They're suffocated, increased intrathoracic pressure, and as a result, a left heart failure. Now, what happened also, the oxygen goes down, transcutaneous CO2 goes up, leading to bradycardia, vagal bradycardia, and unexplained nocturnal death. The pulmonary vasoconstriction because of the hypoxemia and the systemic vasoconstriction. Okay, now there is this recurrent arousal. The patient is having arousal multiple times, leading to what? They're not rested. They're not having enough deep stages of sleep, which lead to excessive daytime sleepiness at night. So the problem is most of the time the patient is saying, "Doctor, I sleep 10 hours, but I still wake up feeling tired and fatigued." The problem is not the amount of hours of sleep, it's the quality of sleep, where most of the time they're spending stage 1 and 2 of sleep. Okay, now the cognitive impairment, which is really common in patients with Down syndrome, most of the theorists were thinking that it is related to the sleep. Because of the interrupted sleep multiple times, because of the apnea, they're having decreased slow wave sleep, which is the deep stages of sleep. Every one of us hope that we'll spend the whole night on the slow wave sleep. And because of the intermittent hypoxemia, that results in decrease of the IQ, reduction in the executive function, attention deficit, and disruptive school behavior. Okay, now this is what I always present to normal adults, where these are what happened with obstructive sleep apnea. We're talking about increased inflammation, increased oxidative stress, metabolic dysfunction, insulin resistant, leading at the end, the clinical outcome in normal adults, these are not even Down syndrome, hypertension, atherosclerosis, congestive heart failure, stroke, cardiac arrhythmia, and increased mortality and sudden death. Tomorrow, actually, I'm talking about the cardiac arrhythmia in patients with obstructive sleep apnea in the cardiovascular conference in Abu Dhabi. These patients are higher risk of cardiovascular mortality. They have 3 times higher risk than normal adult because of the obstructive sleep apnea. Okay, that's an option. For kids with especially big tonsils, big adenoid, you take it out, right? For adults, not really the case. So let's go through what we do again. Maybe I should. So what we like to do for kids, because most of them are having big adenoid and or tonsils, first line, I totally agree. We do adenotonsillectomy. Take out the adenoid and the tonsils. Wait 2 months or 3 months and repeat the sleep study. Okay? If the sleep study resolves, I'm happy, everyone is happy. But if the patient continue to have significant obstructive sleep apnea, then we need something else. We have adjunctive therapy that's always helpful here. Nasal steroid is very helpful. It's anti-inflammatory, and it does reduce the adenoid side, along with leukotriene receptor antagonists like montelukast. Working on weight management is always helpful, because we said that the risk factors, number 1 is weight, obesity, right? Okay, body position, sleeping on the side. Many people are asking me why we like to sleep on the side. When we sleep on our back, we start snoring because it works. You sleep on the side, sleep apnea, severity reduced. Some people even go back to normal, okay? Now, there are other modality with surgeries, again, because of the abnormal anatomy of the upper airway in patients with Down syndrome. And then the last solution, which I never used, is tracheostomy. Okay, what about adult? With adult, we don't start with surgery. We don't do the adenotonsillectomy unless the tonsils are huge, big, of size of 3 or 4, with a malignancy of stage 1 or 2. But we start with something called CPAP, and I'll show you the CPAP in a minute. So what is CPAP? But before I go to the CPAP, so the surgical management, which is adenotonsillectomy, is effective in up to 69% of the patient, but that does not mean that it would fix the problem. We need to repeat the sleep study 2 to 3 months after. Okay? Something that we need to know that these patients, especially who have severe sleep apnea, at higher risk of post-operative complication, which means that you need to tell the anesthesia to monitor them in the intensive care unit post-operatively. They're very high risk, and there are few reports of mortality after a simple procedure, which is tonsillectomy. So we need to monitor them, especially if they're severe and if they're age of less than 3. Okay. The gold standard of treatment in adults is this machine. It's a magic machine. It's called CPAP, which is continuous positive airway pressure. So what is CPAP? So CPAP, so this is someone who's normal sleeping. This is someone who has obstructive sleep apnea. So we need to open this part without surgery. So the solution is having a mask that would fit there with a positive airway pressure that keep the airway open. And that's what the CPAP does. So the CPAP is take the air from the room, humidify it, filter it, and blow it through a special mask to keep the airway open. Okay, so this is someone who's having a CPAP titration. These are the machines that are called CPAP, the continuous positive airway pressure, and it comes with different masks. So the patient comes on the second night. So the first night is a diagnostics, just to see if he has obstructive sleep apnea. If yes, and if it is significant, then he comes again for the CPAP titration study. We cannot give them auto CPAP. We need to find what is the optimum pressure. So they go for the same sleep study, but the next time with a machine, and we manually increase the CPAP pressure gradually until we reach the optimum pressure that abolish all the sleep apnea. Okay, and then we get them the right mask. Now, this is the CPAP titration study. Again, the same sleep study with a machine. Sometimes we start with a CPAP and we end with something called BiPAP, which is especially in patients who have high booth ventilation. Okay. Now, some patients do not need CPAP, and we treat them with body position. So what's body position? It's basically a T-shirt with few tennis balls on the back to prevent the patient from falling asleep on his back. Very simple, effective. Sometimes I even, just to confirm this, I repeat the sleep study again on this T-shirt, and yes, the apnea goes down almost to 0. Okay? Okay, by the way, this is from the Sunnah, right? That we always sleep on the right side. Now here we prove it. Okay, now some adult patient with mild obstructive sleep apnea who cannot tolerate the CPAP, they like to go with oral appliances. So what is oral appliances? Is basically a device that has to be a custom made by orthodontists to build the lower mandible and to keep the airway open. It has a side effects that cause TMJ joint and hypersalivation. Okay, now let's hear what is the guideline and what's recommendation. And anyone who's treating patients with Down syndrome, I recommend that you read this. Guidelines from the American Academy of Pediatrics, Clinical Report on Health Supervision for Children with Down syndrome. So what do they say? Number one, in terms of what are the common disease on patients with obstructive sleep apnea, the most common prevalent things is hearing problem. Vision problems, 60%. Obstructive sleep apnea is 50 to 75%. 50 to 75% of kids are having obstructive sleep apnea. This is something that we really need to monitor, and we need to ask,
our patient when they come to our clinic. So what do they say? I copy and paste from the guidelines. So they say at least once during the first 6 months of life, discuss with parents symptoms of obstructive sleep apnea, including heavy breathing, snoring, uncommon sleep position, frequent night awakening, daytime sleepiness, apneic pause, and behavior problem that could be associated with poor sleep. Discuss symptoms related to obstructive sleep apnea, including snoring, restless sleep, daytime sleepiness, nighttime awakening, behavior problem, and sleep position at every health maintenance visit. Have you ever discussed it with your patient? Now, this is supposed to be at every visit. So this is just to remind you. I know many health professionals, they don't know what is sleep problem to start with, but we need really to ask, we need to discuss with the patient. I just heard from someone who had to travel to Germany just to be screened for obstructive sleep apnea, and that's what they found, and she got the treatment for her child there, where we could do it here. So referral to pediatric sleep laboratory for sleep study or polysomnography for all children with Down syndrome by age of 4 is recommended. So by age of 4, almost every one of them should have a sleep study. That's the recommendation. Okay, so if you need to read further, these are really good resources. The Sleep Disorder Breathing in Down Syndrome from CHEST, recently published, February 2015, and the American Association of Sleep Medicine Guidelines on Obstructive Sleep Apnea. Okay, now to summarize, please, if you have patients with Down syndrome, ask the parents or ask the patient if they have symptoms of obstructive sleep apnea. If you have any questions, you could at any time email me, dr@uaesleep.com.